Hello everyone. Let's start the cardiac portion of the Amedex, that is 2024, that is updated Amedex. And to start with the first MCQ, this is 56-year-old man presents to emergency department with a complaint of chest pain and lightheadedness. On examination, blood pressure is 85/50, rapid and barely perceptible pulse of 160 beats per minute. And the respiratory rate 24 breaths per minute. ECG is obtained, which is shown in the accompanying photograph. Which of the following is the most appropriate next step in the management? So, as I always say, whenever you read the MCQ, first focus on the age of that particular patient, because many a times age is a clue. Not all the times, but yes, you make it a habit to see for the age of the patient first, then look for the chief complaint. Here, the chief complaint is about the chest pain, and the patient is having lightheadedness. So, the patient is having some hemodynamic compromise because the BP is also dropping to 85/50 mmHg. So, patient is not stable at the moment, and on examination you find out the pulse is 160 beats per minute. So we have the a particular problem about the tachycardia, which is pulse is having 160 beats per minute. Whenever you find the cardiac MCQ and you find the tachycardia, you have to look for whether it's sinus tachycardia or it's not a sinus tachycardia. So on ECG you always know that there is a P wave, then QRS complex, and there is a T wave. This is a normal ECG. That QRS complex is preceded by T wave. If you are finding this P wave, that is showing that your sinus is your rhythm is basically a sinus rhythm that is generating from the SA node. So this is a sinus rhythm, whether it's normal rhythm or it's tachycardia or bradycardia. The P wave is important in showing the sinus pattern of that particular ECG. If you are not following your ECG is not following your P wave, or you are not finding the P wave in the ECG, then it's not a sinus rhythm. That is somewhat away from the SA node. That can be your supraventricular or your ventricular tachycardia or bradycardia as well. So in this ECG, this is a QRS complex and this is a T wave. We are not finding the P wave. P wave is missing in all the complexes. We are just finding the T wave and the QRS complexes. So this is definitely not a sinus rhythm. So whenever it is not a sinus rhythm, next step is whether it's SVT, supraventricular tachycardia, or VT, ventricular tachycardia. A very important thing is if you find a very cute, very monomorphic pattern of closely together held complexes, that is most likely SVT. And you when you will find the bizarre complexes like haphazard large complexes of QRS complexes, then this is most likely VT. So in this ECG, it is clear cut SVT, which is supraventricular tachycardia, not the VT pattern. Whenever there is a supraventricular tachycardia, first thing to establish is that the supraventricular tachycardia, the patient is hemodynamically stable or hemodynamically unstable. Hemodynamically stable or unstable. So if the patient is hemodynamically unstable, there is no debate about the medical treatment. Just go for the DC cardio version, straightforward. Like in this case, the patient is having BP 85/50 mmHg, which is patient is about to collapse and he's having hemodynamic instability. So straightforward, our answer would be DC cardio version. But if the patient is stable, you have the options. First of all, you will do the vagal maneuvers, like you can do carotid massage or the cuffing, and patient can try a different vagal maneuvers. And if the patient is not finding benefit from the vagal maneuvers, then the next step is going to be adenosine. That is a good option in the case of VT. And if the patient is not finding a benefit, this is all about the VT portion of this MCQ. Next we are going to quickly just overviewing the MCQ. The ECG's pattern: supraventricular tachycardia, as we already established the diagnosis, tachycardia with the regular and monomorphic URS complexes in the absence of the P wave. So these are the three important clues: absence of the P wave, complexes are monomorphic, like of same shape and size. Here you can see the same shape and size complexes, which is absent P wave. So it is clear cut supraventricular tachycardia, which is SVT. SVT can occur at any age group and treatment can be challenging. It can present with a variety of the clinical symptoms. It can be asymptomatic but can be present with a palpitation, dizziness, shortness of breath, syncope, chest pain, fatigue, diaphoresis. Diaphoresis is a profuse sweating, or the nausea. So these can all be the presenting finding of the SVT. Rare complication can have myocardial infarction, congestive heart failure, syncope, and sudden death can also occur. These complications are most likely in the patient who are hemodynamically unstable. Acute management of SVT include the rate and prevention of the hemodynamic collapse. So we have to control the rate, which is a supraventricular tachycardia. So we have to control the rate, and we have to prevent the complication, which is definitely a collapse, and result, which is a sudden death. Patient with an unstable hemodynamically status like hypertension or the chest pain or dyspnea or perfusion related confusion should be treated immediately with a cardioversion like this MCQ. We have to straightforward go for the DC cardioversion. But if the patient is stable, then the vagal maneuvers can be used to treat the heart rate and convert the sinus rhythm. Weger's maneuver is the right option here. If the patient is stable, if the Weger's maneuver are unsuccessful, then adenosine can be added to the patient treatment regime. If adenosine does not work, then the AV blocking agent in the form of calcium channel blockers or the beta blockers can be added. So the treatment ladder basically for the SVT, that unstable SVT is treated with the here unstable SVT is treated with the DC cardioversion, stable SVC with the Beagle maneuver first, then adenosine, then calcium channel blocker. This is a straightforward MCQ about the SVT. Next comes 67-year-old man. Again, look for the age of the patient. 67-year-old man who is a known case of congestive heart failure. He's an old age patient and already having congestive heart failure. So there is a definitive comorbidity of this patient. He's on treatment and forgets to take medication on the 10-day trip to the France. So he's a non-compliant to medication. Today is in your office with a complaint of bilateral edema of the legs. The patient of congestive heart failure having the edema means patient is having decompensated heart failure. So this patient is having decompensated heart failure. On examination, blood pressure is 165 by 110. Luckily the patient is not in hemodynamic collapse, but he is having hypertension at the moment, and the heart rate is 106 beats per minute, and respiratory rate is 23 breaths per minute. So at the moment the main findings or main problems we are having is decompensated heart failure, having hypertension, and having tachycardia. So we have to control all these modalities in the old age patient who is 67 years old. In heart failure patient, again you will first have to see whether the patient is unstable or stable, or you can say the patient is having decompensated heart failure or compensated heart failure in the form of fluid overload. So fluid is an important thing in the management of the heart failure. If the patient is having hypervolemic, like in this case the patient is having hypervolemic, because he is having leg swelling in the clue of the hypervolemia, then you have to manage the patient with the diuretics. In diuretics, we have safe option of the loop diuretics, which is a good option, but the spironolactone like this case is cause hyperkalemia. And three things you should look for whenever you are giving the spironolactone. The patient is not having hyperkalemia, because the side effect of spironolactone is hyperkalemia. The potassium should be less than 5, and the second thing is the patient should be euvolemic. So in this patient, the patient is having hypervolemic because of bilateral leg swelling, so this option is not good for us. And the third thing you look for the spironolactone is GFR. So spironolactone is not given in the kidney failure patients. So definitely our treatment is going to be we start with the loop diuretics. Next comes the decompensated heart failure. You have to look for the hypervolemia or the euvolemic state. Hypervolemic state is treated with the furosemide, bumetanide, or torsemide in the form of beta blockers, or next step is ACE inhibitor ARBs, which is a cardioprotective medications. Or hypervolemia can present as an increased JVP, increased weight, dyspnea, minimal peripheral edema, crackles, elevated BNP. This is an important clue for the heart failure, and the hepatosplenomegaly and ascites and anasarca. But if the patient is having euvolemic, then the options can be your beta blocker, because the hypervolemia is a good option, or the diuretics is a good option, and in the case of euvolemic, beta blockers is the good option. Beta blockers should not only be started, do not have respiratory crackles, and no more than minimal peripheral edema. So edema factor is again a contraindication to the beta blockers, because there you have a respiratory compromise, like in this patient. With a significant bilateral edema in this patient, hypervolemia should be started on the loop diuretic. Furosemide, ACE, and ARBs should be added in conjunction with the diuretic as the mortality benefit. Spironolactone, as we have already discussed, is given in the euvolemic patient with a GFR of greater than 30 and potassium or less than 5. Digoxin, yes, it is a good option, but for those patients who have heart failure of ejection fraction of less than 35% and who are not treated with the maximal dose of beta blocker, then digoxin is the option. Beta blocker are contraindicated in patients with the heart failure who have volume overload. So only option left was loop diuretics here. Next comes 54-year-old man presents to the emergency department with a complaint of retrosternal chest pain that worse on the inspiration and lying back and relieved with the bending forward. This is a very important line, just to memorize it as such. This is a line showing the typical diagnosis of pericarditis, the pain, chest pain that worse on inspiration, so it is a pleuritic chest pain that worse on the lying back and relieved by the bending forward. This is a typical pain of pericarditis. On examination, the blood pressure is 138/97, so patient is hemodynamically stable. The pulse rate is 110 beats per minute. He is having tachycardia, shallow respiration, breaths of 26 breaths per minute, and the temperature of 38.5. The ECG is obtained, which is showing in the volume photograph. Which of the following is the most appropriate next step in the management of this after the administration of supplemental oxygen? So we have given the oxygen already to the patient, and he is asking about the next patient, next treatment. The itis, whenever there is a word itis, itis, it shows inflammation somehow. So whenever there is an inflammation, there are signs of inflammation like pain, calor, uber, dolor, redness, swelling, all the things. So we have to control the pain of that patient. NSAIDs is very important in the treatment of pericarditis. So answer will be NSAIDs in this case. The clue in the ECG is basically, you can see the depression area in the PR depression here. Like this is a P wave and this is a PR depression, this is a PR depression, this is a PR depression, and there are gross ST elevation in all the leads. This is ST elevation, this is ST elevation. This is not following a typical pattern of MI. MI follows some leads, not all the leads. So this is showing all the leads ST elevation, and somehow the ST elevation showing concavity, this concavity pattern, not typical convexity of the MI. So this concavity or the M pattern is typical for the pericarditis. So for the diagnosis of pericarditis, the history is very important. The pain that is with inspiration and lying back is the history of the pericarditis, and ECG is very important, that is PR depression, or you can say ST elevation in gross all leads and concavity of ST elevation. These are clue for the pericarditis, and we are managing the patient with the NSAIDs. The clinical picture ECG findings are typical for the pericarditis with a pleuritic chest pain. Sometimes you also find friction rub and the fever that are clue for the pericarditis as well. Troponin can be elevated in pericarditis but not very grossly elevated as in MI, and cardiac tamponade is a serious complication of pericarditis. On ECG you will find diffuse PR depression, ST elevation in upward concavity as compared to the upward convexity as seen in the MI. NSAIDs is the primary treatment of choice. Other treatment, whenever you are giving the NSAID, you have to control the you have to give the GI cover in the protection in the form of PPI, which is a proton pump inhibitor, H2 blockers, and the second line management is the colchicine, 0.5 milligram twice daily. This is the important for the pericarditis management. But whenever you are having pericarditis, which is a uremic pericarditis, or the pericarditis due to connective tissue diseases, then autoreactivity, then you give high dose corticosteroid as well in the form of prednisone 1 milligram per kg per day for these patients. Next come a 30-year-old school teacher presents to the emergency department. She collapsed at the school during exercise. So she is a young lady, 30 years old lady with no comorbidities, and she is a school teacher. She was doing her work and during exercise she just collapsed. So this is an exertional collapse. I mean something to do with the increased demand of the body with the blood supply. So the patient is not able to cope with the increased demand. She was unconscious, we received and fully recovered afterward without any medication. She fully recovered. So maybe it's a vasovagal attack, or maybe something related to a missed beat or something like that. She now complains of shortness of breath but denies the chest pain. On examination, systolic murmur is heard over the right second intercostal space radiating to the apex. So there are some concepts that should be crystal clear in your mind when solving the problems of the cardiovascular MCQs. Even though you don't know about the systolic murmurs, even though you don't know about the diagnosis, just looking for the smart play, or if you know the location of this right second intercostal space, which valve is present, you can just and rule of exclusion based criteria, you can solve the MCQ. This is important information, that your left fifth intercostal space medial to the mid clavicular line, mean apex, is a mitral area. Your fourth and fifth intercostal space in the lower sternal border is your tricuspid area, and the second left intercostal space is your pulmonary area, and definitely the right second intercostal space is your aortic area. So in this, the clear cut location is right second intercostal space. Here we are dealing with the aortic area. So even if we don't know much details about the rest of the options, we can straightforward go for the aortic stenosis in this patient. So exercise-induced collapse and the murmur on examination most likely caused by the structural heart disease, that is valvular lesions or the hypertrophic cardiomyopathies. Arrhythmia can be due to cause of the exercise-induced hemodynamic collapse. So the patient is having hemodynamic collapse due to exercise arrhythmia that is not giving rise to the murmurs. And the patient is systolic murmur heard of the second intercostal space, that is due to basically aortic stenosis that is capable of producing murmur, and aortic stenosis always produce a systolic ejection murmur. From aortic stenosis, you can remember A for ejection. Basically it's for ejection, but just for your memorization it's ejection. S for systolic, so it's a ejection systolic murmur in the case of aortic stenosis that is typically heard in the aortic area, that is a right second intercostal space. Murmur is harsh quality and can be transmitted equally to the carotids, because there is too much flow in the aorta. Aorta is a major vessel of your heart, so due to increased velocity of the blood, there is a harsh quality murmur, and it's directly transmitting to the carotids. The murmur can also radiate to the apex of the heart, where it may be different quality. It is also common in the ASD to have mild mitral regurgitation with the systolic murmur best heard on the apex as well. So in the patient of aortic stenosis, you can find two murmurs. First in the apex area, second in the right second intercostal space. The murmur of the patent ductus arteriosus can be both systolic and diastolic, that is called Gibson's murmur or the machinery murmur, with the greatest intensity in the left infraclavicular region. And the furthermore, PDS congenital heart disease unlikely to have present this late. Hypertrophic obstructive cardiomyopathy, which is a HOCM, it's also a very important cause of exertional syncope. However, characteristic of murmur that is described in this scenario is not typical for the HOCM. And the HOCM presents with the most common presentation is left ventricular outflow tract obstruction and the mitral regurgitation. Left ventricular obstruction presents with the crescendo decrescendo murmur, like harsh murmur coming up and down, and the left over the left sternal area that can radiate to axilla but not to the neck. So aortic, it just murmur radiating to the carotids or neck is your aortic murmur. If murmur is radiating to the left sternal border, that is basically your crescendo decrescending murmur of the left ventricular tract obstruction, LVTO, left radiating to the left sternal border. Then come VSD. VSD also has systolic murmur that is greatest intensity in the left sternal border, and the mitral stenosis present with syncope during exercise murmur is diastolic and the greatest intensity in the apex. So just for the learning point of view, your regurgitation like tricuspid regurgitation and the mitral regurgitation present with a hollow systolic murmur, while your stenosis, whenever there is a stenosis, there is a decreased flow causes diastolic murmur. So both the stenosis, this is mitral stenosis and tricuspid stenosis, are producing diastolic murmur, and that is not true. That stenosis mnemonic is not true for this you can say pulmonary area. These are just for the mitral and tricuspid areas. You can apply on this, because the pulmonary area stenosis is producing systolic murmur. So just for now, just memorize these two things. Then we will jump to the other thing as well, that the regurgitation is producing holosystolic murmur and stenosis is producing diastolic murmur in the case of tricuspid and mitral areas. And these are your areas of the heart showing second intercostal space. Right side is your aortic area, left side is pulmonary area. Erb's point is third intercostal space, left sternal. Left sternal, fourth intercostal is tricuspid area, and fifth intercostal, which is apex, is mitral area. So these are important to memorize as such. Next comes 65-year-old female presents undergo percutaneous coronary intervention and stent placement through the femoral artery. So there was a procedure done through the femoral artery. A stent was placed, and after which she was started on aspirin and clopidogrel. 24 hours later, she developed pulsatile painful mass in the groin after the catheter was stented. After catheter, if there is a collection of the mass in the groin area, in that particular area from which the catheter was placed, that is very much diagnostic of hematoma. Hematoma is basically a collection of fluid, and pulsatile mass is showing something related to arterial due to high flow. So basically hematoma is forming your aneurysm. Aneurysm is not truly from the wall of the vessel itself, but it's the collection of fluid that is communicating to the vessel. So it's a pseudoaneurysm, it's not a true aneurysm, it is not formed by the all three layers of that particular vessel. So this is pseudoaneurysm. What is the definitive treatment of this mass? Whenever we are finding the pseudoaneurysm, we have to mobilize that aneurysm, we have to break down that aneurysm. So there is injection of thrombin into the mass is the right option here. The scenario is typical description of the pseudoaneurysm as a complication of the femoral artery catheterization. Pseudoaneurysm is hematoma that forms the result of leakage of hole in the artery, and the hematoma forms outside the arterial wall that is contained by the surrounding fibromuscular tissue, and it is communicating with the artery. So it is a pseudoaneurysm. Pseudoaneurysm, on examination you will find the bruit, on investigation you will find the Doppler duplex ultrasonography, on the treatment you will give ultrasound guided thrombin injection. So these are the three important points in the management or in the diagnosis of the pseudoaneurysm. Other option, that was ultrasound guided compression. Yes, we used to do it ultrasound guided compression, but not now because the compression is so prolonged, about 120 minutes, and it is very uncomfortable for the patient, and early recurrence chances are very high. Urgent surgical exploration is indicated for the threatened limb, and the percutaneous approach is not feasible. So this method is not a good choice for now, but it was a choice before 1985. Vitamin K is not a treatment option. Any option suggesting a cessation of clopidogrel is incorrect. Angiographic intervention by the retrograde approach from the contralateral femoral artery is only indicated if the acute vessel occlusion distal emboli occurs. So this is another option of any complication management, angiographic intervention by the retrograde approach. Next comes a 60-year-old man comes to the emergency department with a complaint of palpitation for the past 2 months. Again, look at the age of the patient, which is 60. Look at the chief complaint of the patient, which is palpitations for 2 weeks. Mean acutely she is presented with this problem. On examination, blood pressure is 125 by 95. She is hemodynamically stable. Heart rate is 160 beats per minute and irregular. Whenever there is an irregular heartbeat, this is a very important clue for the atrial fibrillation. And he is clear cut himself giving the diagnosis to atrial fibrillation. He started on the metoprolol for the rate control, and electrical cardioversion is planned. Which of the following should be used for the anticoagulation? Whenever you are planning an electrocardioversion, it is important, very important to anticoagulate the patient. Why? Because there are very high chances of the thrombus to dislodge, because in atrial fibrillation there is a target that is producing very bizarre waves at that particular site, and due to this particular waves there is the chance of thrombus formation in the atria due to stagnant blood. This thrombus can already be present, but or it can form de novo when you are DC cardioversion the patient. Due to cardioversion, the thrombus is produced de novo. So there is very high chances of this thrombus to dislodge into the pulmonary circulation, causing the pulmonary embolism. So we have to anticoagulate the patient even before the procedure is started. So this is the right option, warfarin 4 weeks before and 4 weeks after the procedure. 1 month is the window period, 1 month before and 1 month after the procedure, which is DC cardioversion. You have to give the warfarin to the patient. Just 24 hours is not the right option. Just aspirin is not the right option. And apixaban, there is no clear-cut study about the apixaban, which is a novel anticoagulant. Converting the atrial fibrillation to sinus rhythm is associated with small risk of short-term thromboembolic events, which are either pre-existing thrombus, more common, or the de novo thrombus formation, which can cause embolization, dislodgement of the left atria thrombi into the circulation due to stagnant atrial flow. Patient undergo cardioversion of atrial fibrillation more than 42 hours duration present with a high risk group, and the embolic risk of 1 to 5%, which can be reduced to less than 1% if we give anticoagulation. Anticoagulation is just 1 month window period, 1 month before, 1 month after, with a warfarin target ratio of 2 to 3 INR. Heparin can be used if there is an emergency cardioversion in the unstable patient who is hemodynamically compromised, which is definitely the case in this scenario. And aspirin is not a good option. And apixaban, there is no clear-cut study, although apixaban is superior to warfarin, but there is no efficacy study conducted for the cardioversion related anticoagulation. Flecainide is antiarrhythmic medication used for the pharmacological cardioversion with no effectiveness in the preventing thromboembolism. So up till now we have just discussed the important topics, which is SVT or the atrial fibrillation or the congestive heart failure. So we will continue our session next, inshallah.